So good morning, everyone, or afternoon, depending on where you're at. Welcome to today's webinar, and thank you for joining us. My name is Deanna Helsher, and I am Director of the Michael and Susan Dell Center for Healthy Living. Today's webinar is hosted by the Michael and Susan Dell Center for Healthy Living at the UTHealth School of Public Health. And this is part of our DPAD collaborative. So I'll tell you a little bit more about that in a second. The center's vision is healthy children in a healthy world. So before we get started, I just wanted to make some housekeeping announcements. First of all, this webinar is being recorded and it will be archived along with the presentation slides on our website at msdcenter.org. And while you're there, spend some time looking around for our resources and some of our other archived webinars. If you have any questions during the presentation, please enter them into the questions chat box. We will have time for a Q&A at the end of the presentation. And so I'm excited to announce our speaker today, Dr. Emily Hébert. Dr. Hébert is an assistant professor in the Department of Health Promotion and Behavioral Sciences at UTHealth School of Public Health. Her research focuses on the use of mobile technology for health behavior evaluation and intervention. She is interested in the potential for technology such as smartphones and sensors and social media to improve research methodology and expand the reach of evidence-based prevention and treatment, especially among socioeconomically disadvantaged populations. Dr. Hébert is really innovative and an up-and-comer in this area, so we're very excited to have her join us. So before she begins her presentation, I'd like to tell you a little bit about our DPAD initiative, or the Digital Physical Activity and Diet Collaborative. This is a joint MD Anderson and UTHealth core, so it's jointly funded by both institutions. So the aims of the DPAD collaborative are to conduct a needs assessment to identify MD Anderson and UTHealth researchers with these interests and identify their needs for training, collaborators, and infrastructure, to provide training and networking activities to support and connect digital health and obesity researchers, and then to create core services. So those include an online resource clearinghouse, consultation and navigation services, and then technical services as necessary. So the outcomes of DPAD are really what we want to do is build infrastructure so that we can successfully compete for NIH and other funding, including partnerships with industries such as STTR, SBIR grants. We also want to enhance researchers' competitiveness for funding priorities, specifically those that are indicated in the 2020-2030 strategic plan for NIH nutrition research. We also want the resulting research to lead to highly scalable and cost-effective interventions to decrease obesity and subsequent disease and disability in Texas. And then finally, we interface with the newly formed Texas Network of Obesity Research, which involves various institutes of higher learning across the state. So the leadership is shared among MD Anderson and UTHealth. And so Dr. Karen Bazin-Inquest is the lead with Dr. Susan Peterson and then Tuan Lee as our administrator for the project. At the UTHealth side, I'm one of the leads along with Leah Wiggum, Dr. Leah Wiggum, and Dr. Sahidi Manini. So with our scope of work, we've conducted a needs assessment. This is part of our webinar series, so this is part of our scope of work. We also have are going to set up some digital health training. And one of the things we're most excited about is we'll have a symposium on September 8th and 9th at UTHealth School of Public Health. So there are abstracts that are due tomorrow on Friday that should be sent, and I will put the link in the chat box so y'all will see that. And then there's a registration form. So the symposium is free, and so we encourage you, if you have a chance, to attend that seminar. And then the last thing we're preparing to do is to provide core services. So based on the needs assessment, we're going to put these core services into play probably later this fall. And the last slide I have here is just another slide introducing the Fall 2022 Symposium, tells you a little bit about the times, and then talks about our keynote speaker, who is David Conroy from Penn State University, who does a lot of this type of work. So we hope to see you there. And so now at this time, I'd like to turn the presentation over to Dr. Hébert. So Dr. Hébert?
All right, thank you, Dr. Helscher, for that introduction. I'm excited to talk with you all today. Today I'm going to be talking about an emerging intervention style that's really geared for smartphone-based interventions called just-in-time adaptive interventions. And I like to refer to it as sort of a counselor in your pocket for reasons that will become clear in a few moments. So I want to start with a guiding example that I think most of us are familiar with. So I would imagine quite a few of us either have activity trackers like Apple Watches or at least familiar with the concept. But most Apple Watches have a feature where after a specified period of time, say an hour, if you've been sedentary, the watch vibrates and then you get a message saying it's time to stand up and move around for a minute. And the first question I have is this an effective intervention? If you have a fitness tracker like this, think back to the time where you've gotten a message like this and think about how you felt in that moment. Did you listen to the message? Did you actually stand up or did you ignore it? Well, it turns out that most people actually don't love it. If you do a quick Google search, you get articles like these. The first question people have is how to turn off those annoying stand reminders on Apple Watch. And so when we're doing mobile health interventions, one of the questions is, why doesn't this work? How could we possibly improve this so that it is something that someone is receptive to and that we could use this technology to actually help increase healthy behaviors? So I always like to start with sort of an explanation of why I'm so interested in using smartphones for health behavior change. I think there's a common perception that smartphones and technology is really limited to wealthy individuals. But as a matter of fact, smartphones are so ubiquitous in the United States, 85% of all US adults own smartphones. The number is even higher for cell phones that aren't capable of accessing the internet. I believe it's 97%. But smartphone ownership is high even among individuals with low socioeconomic status. Among those making less than $30,000 a year, 76% of individuals own a smartphone. And so the takeaway from this for me is that smartphones provide an opportunity to reach a wide and diverse audience with health behavior interventions. These are individuals that have a smartphone out of necessity just for engaging in daily life, but may not be able to, for example, get physically to a clinic for treatment, or may not have time to engage with intensive counseling regimen. So smartphones are one way that we can possibly increase access to evidence-based treatment. And what this has given us is really more granular data than we've ever had before. And I know those of you in the DPAD consortium are very familiar with this, but health monitoring is just kind of a part of our daily lives. Many people download health apps to track their own behavioral health, but we also have smartphones and we have fitness trackers and we have sensors and the full Internet of Things that is all giving us just-in-time momentary data, continuous data about someone's circumstances and health behaviors. So most people, I think, are familiar with sensor technology, but I wouldn't be able to talk about just-in-time adaptive interventions without talking about a measurement strategy that we use called ecological momentary assessment. And all this is a collection of methods that is using smartphones to assess real-time data on subjects' behavior and experience in their natural environments. This, before smartphones came about, was more commonly known as time diaries or experience sampling. But now that we have smartphones, EMA can be something that is really powerful for understanding the detailed process that people undergo when they're trying to change a health behavior. So the reason that we use EMA is, number one, retrospective recall is subject to bias. So I know, this group studies a lot of dietary behaviors, and the food frequency questionnaires are fantastic, but if you were not asking about diet from a recent period of time, it may be difficult for people to remember some of those important details. So EMA is one method where we could evaluate diet on a momentary or daily basis. EMA is also useful for addressing something called the availability heuristic. And this is a mental shortcut that we use when we have to estimate frequency of behaviors or experiences. More recent experiences weigh heavily than distant experiences. So for example, if I asked you how many servings of tomatoes you had last week, if you had just had a tomato for lunch, you might say, oh, well, I eat tomatoes all the time. But that may not be representative of the actual frequency over a longer period of time. So EMA is one way to account for this. The other important factor is that it accounts for socio-environmental characteristics. And what I mean by this is that this is not a measurement that we're taking in the lab. There's lots of evidence to suggest that people may answer questionnaires differently when they're in a laboratory or a formal research setting. And these are questions that are asked about in the moment. And if you think about it, someone's mood or stress or current context may impact the way they answer questions. Finally, EMA is really ideal for studying dynamic behaviors and experiences. And what I mean by that is things that change from moment to moment or may change depending on the context that someone is in. So if you think about it, a lot of our health behaviors are dynamic. Whether or not you work out may depend on your mood or who you're with, or if you have time, how you're feeling that day, health-wise. So it's really powerful to have a tool that can measure at smaller increments and understand within subject patterns of behavior. So with EMA, there are two main strategies for sampling. The first is time-based. And this is when we push assessments either on a fixed schedule, so something like a daily diary, 30 minutes after someone's waking time, or random assessments. So what we'll typically do is we'll have assessments pushed at random intervals during someone's waking hours so that we can get little snapshots in time of their behaviors and experiences. The other sampling strategy is event-based. And this can either be participant initiated. So for example, we tell somebody, we want you to go into the app and push a button when you're eating a meal. Or it could be sensor initiated. So there are a lot of studies out there that use something like physical activity level measured via accelerometer to trigger an assessment, like, are you working out right now? Or it could be something like GPS. If somebody walks into a geofenced area, let's say near a McDonald's or something, you could prompt an assessment and ask them about what they're doing or what they're planning on eating. And this screenshot here is just an example from one of our surveys that is looking at smoking cessation. And as you can see, the question is referring to the time period right now. So what does this look like if you were actually going to do a study design using EMA? So this is an example from one of our smoking cessation studies. And you can see in the timeline that we usually divide up measuring the health behavior by meaningful periods of time. So if we're delivering an intervention to help someone quit, we might be interested in observing their behaviors and experiences before the intervention in the pre-quit period, as well as during the quit period and after the quit period. So what this looks like is that we might do 5 EMAs a day. So we're pushing 5 surveys during the course of the day, including a daily diary, and then 4 random EMAs during waking hours. So they're not delivered at the same time every day. We're getting little different slices of life from day to day. We also will include participant-initiated EMAs if we're specifically interested in a health behavior like smoking or urge to smoke. So we instruct individuals, if you have a craving to smoke, go into the app, push a button, and then we can really understand what they're experiencing in that moment. So what do measures look like for this? Unlike a traditional cross-sectional survey that might ask about behaviors over the last week, we're really asking about things in that moment, or in some cases, it might be 24-hour recall about how someone felt yesterday. So typically we'll include core items. So we'll include the same questions on every type of EMA. And we are typically asking about things that we know to be closely associated with that behavior. So we'll always evaluate the behavior, smoking status, since the last assessment, have you smoked? And we'll ask about mood, affect, environment, if they're by themselves, where their location is, if they're at a bar, if they're at home, their motivation to stay quit, and then their self-efficacy to stay quit. And then on a daily diary, we might ask things that are less frequent or that are not our primary behavior of interest. So we'll ask about yesterday's smoking behavior as well as related factors like alcohol use, physical activity, or sleep quality. And then finally, on those smoking assessments where we're really getting in the moment what's going on when they're doing that behavior, we'll also ask about things like, did you have any warning signs that let you know you were about to smoke? Or are there any coping skills that would have helped you prevent smoking in this context? So what should you measure with this and when? The first question that's important to ask is, how much does the behavior or situation vary? So EMA is really great for things that are dynamic, but you wouldn't ask someone 5 times a day about something that only happens once a day. So for example, if you're doing a medication adherence study and they only take the pills in the morning, you're not going to ask them 5 times a day, did you take your pill? Did you take your pill? But you might ask 3 times a day for diet or snacking. The other thing to take into consideration is that we're trying to balance participant burden with recall bias. So it's obviously important to ask about something frequently enough that someone can accurately remember the context of what was going on. But we also recognize for future scalability, we don't want to bombard somebody with an EMA every minute because they're not going to answer, it's going to annoy them, and we're not going to get good data that way. So it's always a careful balance. I always show this graph because it's important to consider the frequency of these measures. So this is a graph of a paper by Saul Schiffman that was looking at negative affect as measured on EMA in a period of time leading up to a lapse. So smoking a cigarette during a quit attempt. And on the left side, what we see is that they've aggregated the data down to the daily level. So if you were only asking about somebody's negative affect once a day, what you see in the days leading up to the smoking lapse is there's not really a clear pattern there. So you would assume, based on those data, that there's not a relationship between negative affect and smoking lapse. But on the right side, they've looked at the same data, but on the hourly level. And what's interesting here is measured at that frequency, we see a steep linear increase in negative affect in the moments leading up to lapse. So that's what the power of EMA is that we've discovered this pattern and we've discovered this window of opportunity where if we can detect when someone's negative affect is getting worse, that may be a risk factor for smoking a cigarette. The other thing that I always consider is that you shouldn't use EMA to measure things that can be better measured passively. So sometimes we will ask about physical activity, but it's much more preferable not to burden someone if you can use an accelerometer and get granular data that's objective rather than their momentary self-report of that. So what have we learned from EMA? Across multiple health behaviors that have used this methodology, we have identified that there are multiple dynamic influences on health behaviors. So regardless of what it is, whether it's substance use or diet or physical activity, consistently, we see factors like mood, stress, social context, and environmental cues being important predictors of whether or not someone engages in a health behavior. And more importantly, we've discovered that the importance of predictors may change within person and over time. So this graph is one of our papers that was looking at a time varying effect model of risk factors for smoking lapse. And I won't go into the details too much, but what's important to see here is that these lines are not straight. So in these plots, essentially it's looking at an individual factor like urge to smoke and its relative importance on the risk of smoking lapse. And what we see is that it changes from day to day. So for example, urge to smoke may be the most important predictor on day 1 of a quit attempt, but on day 5 of a quit attempt, negative affect or stress might be a more important predictive factor. So what we've learned is that there are really changes within an individual that a static intervention may not be well suited for. So especially within behaviors like substance use and dietary lapse, I often use a theoretical model called the relapse prevention model. And this is Marlatt and Gordon from 1985. But essentially what the relapse prevention model says is that when somebody encounters a high-risk situation, their coping response is what determines their ultimate success. So if they have an effective coping response, that increases their self-efficacy, and they have a decreased probability of relapse. But if they have an ineffective coping response that decreases their self-efficacy and their positive outcome expectancies, that can lead to the initial use of a substance or maybe a dietary lapse, and that can lead to the abstinence violation effect, which is essentially the idea of like, well, I already ate one cookie, so I might as well finish the whole bag. And that can lead to an increased probability of relapse. And the reason this is important is because it shows that an early intervention in that high-risk situation can really make or break the effectiveness of the intervention overall. Within the context of smoking studies specifically, we've also found that the real-time reports of smoking lapse suggest that a trigger, there are only mere minutes between a trigger and whether or not someone decides to lapse. And so we have this idea from these data that if you had a counselor in your pocket, if you had someone who could help you in that moment, you could really prevent someone from lapsing and encourage that healthy behavior and increase the success of your intervention. So that has led to an idea called the just-in-time adaptive intervention, or the JITAI, kind of like Return of the Jedi. So that's what I'm referring to when I say JITAI from now on. So the idea behind a JITAI is essentially it's tailored support delivered in the moments it's most needed. And it's using dynamic information from smartphones, from wearables, to modify the type, amount, and timing of the support. And so the essential idea is that we're trying to provide support, the right type of support when it's needed, and importantly, not when it's not needed. So I love this screenshot. This is from someone's notifications of Pokemon Go, which was a game app in the summer of 2016 that actually had a component that encouraged a lot of physical activity. So you can see this notification here, why not step outside for a bit, at the same time as they're getting a tornado warning from a different app. So this is really the idea. There are times that people will be receptive to intervention, and there are times that the intervention is not appropriate or they won't be receptive. And this is a good example of why this balance with the JITAI is so important. So with mobile interventions, we see two main types of intervention content. I think what we're most familiar with most health apps on the market is pull content. So this is content that's made available to users on demand. It's educational materials. It could be things like self-monitoring graphs or charts, or it could be tips for encouraging a healthy behavior. But the idea with pull content is it's the user opening up the app and getting that content. In a text message intervention, that could also be something like texting the word crave to a helpline. On the other hand, JITAIs really utilize push content. And so this is content that's automatically pushed to the user through notifications, reminders, text messages, or phone calls. And the content can really take any shape. It could be, a tip, a coping strategy. It could be a meditation video for mindfulness. It could be an audio file. We've really seen it all, but the key difference is how the content is delivered to the user. So let's walk through a conceptual model, and bear with me, I know this is a little bit busy, but with a JITAI, the first step is a decision point. So this is the time that the intervention is offered. Then we have tailoring variables, and this is information about the individual or potentially their context. So I'm not just talking about demographic characteristics in this case, I'm also talking about real-time factors, like what is their mood in that moment? Where are they located in that moment? Then we have intervention options, which are the possible treatments or actions. So that's, is it a motivating message? Is it a phone call? Is it a video? And then what brings them all together are the decision rules. So that links the intervention options and the tailoring variables, usually with if, then, or else statements. And JITAIs are really suited for addressing proximal outcomes, or our short-term goal, as opposed to the distal outcomes or long-term goal. And what I mean by that is that You wouldn't use a JITAI for weight loss broadly as the outcome. The JITAI is really targeting those granular micro behaviors. Like, are you preventing lapse from a healthy eating prescription, for example? That would be the proximal outcome that the JITAI is really trying to address, because it's a dynamic behavior that is contextually important. So when would you use a JITAI? Number one, it's really suited for things, behaviors or outcomes that are frequent. So number one, you wouldn't really use a JITAI for something like an annual cancer screening, because you don't have multiple time points. That's only something that's happening one time. The whole spirit of the JITAI is that we are adapting to someone's individual context. It would also be appropriate if you have evidence to suggest that your behavior varies over time depending on context or situation. So this applies to quite a few health behaviors. I'm sure we can all understand that if you're trying to eat healthy, who you're with, if you're at a restaurant, if there's a food advertisement, all of those external factors may impact your behavior, as well as internal factors like if you're stressed out, if you have self-efficacy to stick to your diet. Then finally, a JITAI is appropriate if you have evidence either from EMA, sensors, or theory about potential tailoring variables. So you don't just jump to the JITAI. This is something that would happen after the kind of data collection that the DPAD consortium is doing, where we have granular details about an individual and their health behaviors. So example tailoring variables could be things like demographic characteristics. So for example, we have evidence that men and women respond differently to smoking triggers during a quit attempt. Men respond more to environmental contextual factors, like if they're at a bar or around other smokers, and women tend to respond more to internal factors like their mood or stress level. So you could certainly incorporate that into a decision rule for delivering a JITAI. Also contextual factors that I talked about, like location, social setting, and personal cognitive factors like mood, stress, or motivation, you could also see may impact someone's receptivity to an intervention. So let's go back to our guiding example about the Apple smartwatch and how we might be able to improve it. So I'm not trying to rag on Apple, but full disclosure, I wouldn't necessarily consider this intervention, even though it is just in time and in the moment, to be a JITAI, because it's not really adapting to the user at all. So if we're using the JITAI conceptual model, the decision point for this intervention would be the wearer has been sedentary for 60 minutes. So that is the time point where it's evaluated and deciding whether or not to deliver the intervention. And the decision rule can be, if the wearer is sedentary for 60 minutes, then vibrate and push a message to tell them to stand up. So the proximal outcome here would be daily physical activity, and the distal outcome is trying to get someone to meet physical activity guidelines more broadly. But my question for you is, what are the tailoring variables here? And this would be my suggestion for how to improve this, is if we think about it, if you've gotten one of these and you ignored it, well, one reason might be that you get so many of these notifications during the course of the day that you get habituated to it and you start to ignore it. So maybe it's not an issue of delivering this message every single time someone is sedentary for 60 minutes, but picking and choosing times when they would be most receptive to a suggestion to stand up. So that could include tailoring variables, like you could look at their phone calendar and see, is the individual currently in a meeting? Can they even stand up? It could be something like, what is the weather like outside? Is now a good time to suggest that they go outside for a walk? Or is there a tornado like we saw in the other example of notifications? So this is really taking something that we're familiar with and turning it into a JITAI so that we are actually addressing the individual's specific context so that we're more likely to get them to actually do the behavior that we're suggesting. So now I'm going to walk you through an example from my own work that's specific with smoking cessation. So we have developed a JITAI for smoking cessation called SMARTY. And we started with a pilot study where we used this treatment as an adjunct to conventional smoking cessation therapy, including counseling and nicotine replacement therapy. So in SMARTY, participants completed EMAs 5 times a day for 3 consecutive weeks. We did 1 week of pre-quit and 2 weeks of post-quit. And we used their EMA responses to assess their current risk of smoking lapse and then automatically push a tailored message to that situation. We had a weighted algorithm based on the presence of lapse risk factors. So we used data from prior EMA studies where we had a pretty good idea of what kinds of things were associated with smoking lapse. So here's what the messages and the decision rules looked like. So when someone completed an EMA, if their motivation was 0, they were completely uninterested in continuing with the study or trying to quit smoking, we would not give them a further message. We would deliver a message that maybe encouraged them about the benefits of quitting to try and get them back on the wagon, but we recognized that they wouldn't be receptive to more specific advice. So we kind of gave them a level 0 message. If they completed the assessment and they were at a low risk of lapse, they would get a generic message saying, keep up the good work, reminding them of the benefits of quitting, keep doing what you're doing essentially. But if they were at a high risk of lapse, they would then get a tailored message that was specific to the highest risk factor of that moment. So for example, if it were stress, they would get a message that says, don't let negative emotions keep you from a healthier life, and then had some suggestions to reduce their stress in that moment. So we also had messages for urge, cigarette availability, and low motivation to quit. So they were really getting messages that were tailored to what was going on with them in that moment. So this was a pilot study, and we didn't have a control group. So the first question we evaluated with this pilot was, do the tailored messages actually work? Are they reducing the smoking lapse triggers? And fortunately, the answer to that question is yes. So when we compared messages that were not tailored to a specific factor with those that were tailored to whatever the highest risk factor was, tailored messages were more effective than non-tailored messages in reducing that lapse trigger by the next assessment. And that is in line with thinking of tailoring for interventions in general. This was expected, but it was promising of like, hey, this could actually work. So then we did a follow-up study called SMARTY-2 that was a pilot randomized controlled trial with 3 arms. So we had the SMARTY-2 intervention that I've just described, where we got these real-time tailored messages. And we compared it with another standard smoking cessation app by the National Cancer Institute called Quit Guide. And Quit Guide is a mobile app, but it doesn't have any just-in-time adaptive intervention components. It is just pull content. So it had features like allowing someone to complete a journal entry, or they could record their smoking triggers, but there was no real-time adaptive component. That was compared to a usual care in-person smoking cessation counseling intervention that's really the gold standard. And all 3 treatment groups both answered EMAs so that we could look at treatment mechanisms and sort of how the symptoms for lapse risk progressed during the course of the study. And then all 3 groups got nicotine replacement therapy, which is standard of care. And what we found was really interesting. So again, this was a pilot study. It wasn't powered to detect main results of smoking cessation, but we found a couple of things that were really promising. So number 1, at the quit date and 4-week post-quit visits, participants answered questions about their satisfaction with the program. And we used a measure of a treatment provider alliance question, where it's really designed for counselors of like, how well did you jive with your counselor? How well did you feel like your counselor understood your needs? But we adapted it so that it could be asked about each treatment group. So instead of counselor, it was just treatment. And so they would answer it about the JITAI instead. And number 1, what we found is that both of the app-based interventions performed at least as well as the usual care group in terms of response rates, engagement with the intervention, and participant perceptions of the treatment. But where there were significant differences was interesting. So number 1, in the SMARTY group, more individuals, there was a statistically significant difference between the Quit Guide and the SMARTY group in terms of the answer, my treatment knows how to help me quit smoking. So participants in the SMARTY group were comparable to those who had an in-person counselor in terms of their feelings of how well the treatment was adapted towards them. We also asked the question for scalability reasons, do you find the smartphone application to be annoying? So we were referring to sort of the EMA delivery. And what was interesting is that the participants in the Quit Guide, where the EMA really had no bearing on their treatment whatsoever, really found it annoying. But those in the usual care group and the SMARTY group didn't find it as annoying. And when we evaluated that in qualitative interviews, it was because they felt like the answers they were giving actually influenced their treatment. And they could see that in the treatment messages, like, oh, I just answered that I was stressed and I got a stress message specifically. So that was really encouraging. As far as smoking cessation outcomes, this was also preliminary because it's not powered, but it was really promising in that a total of 17% of participants were biochemically confirmed 7-day point prevalence abstinent at 12 weeks post-quit. And there were no statistically significant differences across groups. So our takeaway from this is that smartphone-based smoking cessation treatments might be capable of providing similar outcomes to traditional in-person counseling. And the implications here are really important because it's really rare for someone to be able to go and attend traditional in-person counseling for a health behavior like this, for substance use. So if we can find comparable results as in-person counseling with this kind of level of personalized treatment, I think that's something that's really important and powerful and potentially reducing health disparities associated with smoking and other behaviors. So JITAIs are still kind of an emerging field. If you do a literature search, most of what you'll find out there is pilot studies, and we're just now seeing a wave where we're seeing fully powered randomized clinical trials evaluating major outcomes. But I will say that JITAIs are really well suited for behaviors like physical activity and diet, because as I said, they are dynamic. They do vary within person over time and by context. And there have been multiple JITAIs that have targeted obesity and weight management, physical activity, and eating disorders. So here I've got a screenshot of one JITAI to prevent dietary lapse by Stephanie Goldstein. And they had an app called On Track that used EMA to measure dietary lapses from a prescribed diet program, and then provide a personalized intervention using machine learning to determine their lapse risk. So these are screenshots from the app. You can see on the left side, those were their EMA responses. And in the middle, you see an example of the just-in-time adaptive intervention, where the participant is told their risk of lapse, and then they got contextually appropriate coping strategies for each of the risk factors that were relevant to them in that moment. So you can see the potential for this kind of intervention design. When we're thinking about designing JITAIs for the future, the number one question that we have to think about in terms of scalability and turning this into something that isn't just a paid research study, but is something that we could put on the App Store and reach a ton of people, is number one, this idea of habituation. So that's the diminishing of a psychological or emotional response to a frequently repeated stimulus. I think we can all relate to this. If you are just getting slammed with notifications on your phone, you start to ignore them. So part of the power of the JITAI is that we're not only identifying moments where someone needs an intervention, we're also identifying the moments where they don't need an intervention. So the idea is that we are bothering people as little as possible, and we're only really providing support in the moments it's most needed. The other consideration is how to limit participant burden. So one of the current limitations is that a lot of these JITAIs are based on self-report data from EMA. And if we have to collect that data 5 times a day, obviously that's not going to be something that's scalable to the general population who's not being paid to complete those surveys. So a lot of the considerations in the future iterations of JITAI involve using passive data instead of self-report, involve using analytic strategies where we're only asking questions where there's a level of uncertainty about the behavior, for example. And then another consideration is, how do we optimize an intervention like this? We can design intervention content and come up with coping messages, but how do you know if that's effective? So that leads to an emerging trial design called the micro-randomized trial, which is really exciting. So in a typical randomized trial, participants are randomized to one treatment condition or the other. But in a micro-randomized trial, which is specific to JITAIs or these momentary interventions, participants are randomized hundreds or thousands of times at each decision point to different intervention options or components. And the goal of this trial design is to optimize the interventions by assessing the effect of the intervention components and whether the effect varies over time or by context. So this example here is from an intervention for physical activity called Heart Steps. So Heart Steps consists of a activity tracker wristband that monitors step count throughout the day. And then there's an Android application that's designed to encourage walking. So participants received contextually relevant suggestions for increasing their physical activity that are relevant to their situation. So it takes time of day, location, weather, and day of the week into context. So in this micro-randomized trial, at the decision point where somebody is about to get a physical activity suggestion, they're randomized to different types of interventions. So they would either get a walking suggestion, an anti-sedentary suggestion, or no suggestion. And the power of this is that we can actually individually identify, are some treatment messages more effective in certain situations than others? Are certain treatment messages more effective over time? And it's really powerful because this is how we can really refine sending messages when it's really important, when it's likely that someone's going to be receptive, and when it's appropriate to their situation. So they're not getting the message to stand up in the middle of a meeting, for example. So for future directions, as I alluded to before, a lot of the research is focused on establishing the actual powered effectiveness of these interventions and improving their scalability. So that involves reducing participant burden by decreasing the amount of information that we have to get by active self-report and relying more on passively collected data. And then there's also a really exciting field there in which we are trying to better predict these health behaviors. So I have a current R00 that's using machine learning to predict when someone is likely to smoke a cigarette during a quit attempt. And before, our JITAI was driven by an algorithm that was a simple weighted linear algorithm. Like, if this risk factor is present and the person reports this, then we deliver an intervention. But what we've learned from our EMA research is that the importance of predictors changes over time. So that's why we're looking to strategies like machine learning, which can accommodate new data, which can really take into consideration all of the variables at once. So it's not just a linear prediction, it's something that is dynamic and responding to someone's needs as they might change over time. So I hope you can see the potential possibilities for something like this for health behaviors, especially when we're already collecting all of this really interesting granular data. I just want to quickly acknowledge my co-investigators. The SMARTY trial, the PI for that was my postdoc mentor, Dr. Michael Busenel and Dr. Darla Kenzer, and two statisticians that I've worked with that are lovely. I have no financial disclosures, but research in this presentation was supported by NIDA and NCI. And that'll do it at this point. I would love to take your questions.
Emily, thank you so much. That was really a great presentation and really gives us a lot of food for thought. So we do have a few questions, and I have some as well. So the first one, and I think that this is one that's probably on a lot of people's minds, is a lot of times people are concerned about releasing data to apps. So have you experienced this in research? How do you talk about it with your participants?
Absolutely. Yeah, we have a pretty good informed consent process in general where we detail how we're using their data, if it's identifiable. And I love this question because it's funny that I feel like people who aren't in research studies sort of willingly give up their information to apps and social media companies without second thought, but we care so deeply in research for good reason. But there are, for mHealth researchers, some sort of established best practices and guidelines about how to use the information and how to talk to participants. And I'm happy to share that link with others. But there's a research core in California where they've collected a lot of considerations from IRBs across the country and have kind of a best practice checklist for mHealth researchers of how to handle data. I will also say that most participants that we talk to are actually really excited by this. They like the idea, they're already using health apps, so they pretty willingly give up their information because it's very clear to them how it's being used. There's a story that I've heard from other mHealth researchers where there was a study at Northwestern, I think, where they were observing dietary behavior and actually had a camera mounted on the participant's shoulder to actually look at things like fork to mouth. And the IRB was really concerned about bystanders being caught on camera. So participants were given this little business card to explain the study and hand it out so that people understood, okay, we can delete your video footage if you don't want to be on camera. But the response was actually curiosity. Most of the participants said like bystanders came up and wanted to participate and were really curious about it. So just something to consider in the way that I think we deal with technology. We're always going to be more careful in research than I think corporations are or other commercial health apps are using the data.
Yeah, that's certainly true. Another question is, what is the process of developing an app? Do you work with software companies to create apps?
Yes, and this is a common question. So number one, the EMA methodology, there are several commercial companies that are similar to Qualtrics or REDCap in that it's a survey platform where you go in and enter your questions and can dictate the schedule, and the participant can download an app that will deliver the EMAs. So for the data collection side, there are a lot of accessible options to researchers. I've also seen several papers that have talked about how to do EMA using Qualtrics or REDCap with a text messaging service. So that part is pretty accessible. If you're doing a JITAI specifically, that usually does entail custom development. I'm aware of a few research outlets where there are shared resources that are available to the public where you could contract with a development company that's already sort of developed a JITAI. But because they're so customized, because the decision rules are going to depend, you're typically working with a developer. And I don't really have great suggestions about how to approach people on that. You know, I think there are a lot of mobile app companies that are capable of doing this kind of development work. It's not necessarily that complicated if you're just using EMA. It's more complicated if you're using wearables and having to consolidate sensor data as well. So if you email me offline, I'm happy to provide suggestions to anyone who's interested in embarking on developing their own JITAI.
Yeah, that's always an issue, trying to consolidate the data into a usable form.
Precisely.
So, when you have so much. So a couple of other questions. One is, where else can this be used other than smoking and diet? And then kind of related, is there anywhere you'd like to take this in the future?
Yeah. Honestly, any dynamic behavior. So I have seen JITAIs and talked about JITAIs with people for physical activity, for diet. It's useful for a lot of mental health conditions. So I've seen JITAIs for suicidal ideation in adolescents, for example. Any substance use behavior, so not just smoking, anything that's impacted by contextual factors, opioid use, alcohol use disorder. I'm involved with a JITAI for that. I'm working with a colleague now of potentially developing a JITAI for adolescent oral health behaviors. So that could be a health outcome like physical activity or diet, or it could be toothbrushing potentially. So I would love to see it anywhere it makes sense. I think if people are downloading health apps to deal with a condition, there's probably the potential for a JITAI there.
Great, great. So how did you go about selecting the machine learning algorithm for your JITAI?
Yes, that is a different presentation probably, but briefly, in my current grant, I'm using supervised machine learning because we have labeled data where we have identified from prior studies, here's when a lapse happened, here are the context and circumstances of what's going on prior to that lapse. We are using gradient boosted trees. And it was really a process of, we tried several popular machine learning libraries and algorithms, and the one that ended up being the strongest in terms of predictability was one called XGBoost, which is just a randomized gradient boosted trees. I'm happy to talk about that. That's a different presentation, but essentially we tried several and just compared their predictive capability and landed on that one.
Great, great, thank you. So another couple of questions is, one is, you mentioned geofencing and you kind of described it very briefly. Can you go into a little bit more detail? Because I think especially with food environments is kind of where my mind goes
Yes.
with some of the geofencing.
Yes, absolutely. Yeah, thank you for that question. So geofencing, I consider one of the passive ways of triggering an intervention. And so where I've seen it is a geofence is using the GPS data from your phone or activity tracker. And the decision rule is essentially if someone enters this area, then that can trigger an intervention. So I've seen it for smoking where participants self-labeled high-risk smoking areas for them. And when they entered in close proximity of that, then they would get a message. The geofence usually, and I forget, because forgive me, I'm not a GIS researcher, but I think the accuracy is between 30 to 50 feet generally, and depends on which device they have and things like that. But you could imagine the potential. I mean, I've joked multiple times about having an intervention where we detect someone walks into a McDonald's and we can send them a message with some healthy options on the menu or something like that. So I think that's really powerful, and I would love to work with anyone who's doing GIS work to consider ways that we could use GPS location as one of the tailoring variables.
You know, talking about people using data for this, in our street study, we were looking at kids' physical activity, and specifically in how they walked to and from school. You know, did that increase over time when you change the environment? And we had accelerometers, but we also had GPS units. So not only could you find out if the physical activity changed, but did their routes change kind of over time? But interestingly enough, the GPS unit, a lot of parents were very concerned about that, which always, to your point earlier, is kids have phones, you know, so that tracking of them was very easy. And our GPS unit, you had to have very specific software to look at it, and it was kind of difficult for us to get data on it. So anyway, that was the part that they were most worried about.
Yeah, I can understand that, but it is funny how I think people understand the data that's being collected of them commercially outside of a research study. I will say we've looked at GPS data in the past, and one of the challenges with it in developing JITAI is that it's often not generalizable in and of itself. Like if I have a GPS coordinate, I can't use that, for example, in a machine learning algorithm to say, oh, well, this coordinate is a risk factor, because it's really only applicable to that individual, and the functional meaning of that location is what's more important. So is it their home? Is it a friend's home? Is it a bar? So that tends to be how we use location data. So we're very rarely keeping or maintaining the exact GPS coordinates. It's more, what does that tell us about someone's risk?
So kind of the last question I have here is, I really love this for diet implications, because when I talk about dietary behaviors, I always talk about people making literally hundreds of behaviors a day. So, you know, what time are you going to eat breakfast? What are you going to eat for breakfast? The foods you eat for breakfast are different than the foods you eat at lunch. What makes you decide to get a snack or not? So, do you think in the future we're probably going to use more of these? I mean, as it is right now, a lot of apps are food diaries, essentially electronic food diaries that you're following.
Yeah, I hope so. I mean, we certainly have the data already, right? There's so many researchers collecting this really granular data about all these decisions. And so what I'm most excited about and what I hope for the future is that we get better at predicting behavior and intervening earlier. So with diet, I mean, you could probably look at my calendar for the day and have a pretty good idea if I'm going to be stressed out that day. And then like it's a factor of like, what do I have in my refrigerator right now? You know, like those kinds of food decisions you make are impacted by all of that. And so if we could use all that information and maybe like warn someone, hey, on Friday, you have a stressful day. Why don't you plan ahead now, a meal plan, so you stick to your diet? I mean, that's where you really start to see the power of using this information for good. And that tends to be my soapbox, is that like, we're already collecting so much personal data. Why don't we use it in a way that is actually helping someone, where they feel empowered by the way that their data are being used, and they start to understand all these little micro patterns, and knowing, you know, we're preventing abstinence violation effect, right? It's like, it's okay if you eat the one cookie. Here are all the things we can do to help you to prevent that in the future and keep you on track. So that's what I'm excited about from this.
Yeah. Well, I really loved your presentation and think it has a lot of applicability to a lot of what we do. So I'm hoping through DPAD we can kind of get more people using these interventions and perhaps talk to you about future partnership possibilities.
I would love that. Yeah, I'm very excited by what you guys are doing. I think there's a lot of cool stuff we can do together.
Great. Well, thank you so much. We really appreciate you taking the time out to do this presentation. I wanted to remind y'all again that this is being recorded and it will be archived on our website at msdcenter.org. We appreciate y'all being here, and if you look in the chat, we also have some instructions on submitting an abstract and then the symposia link for registration, and we'll follow up with that as well. So we will have some upcoming webinars, so be on the lookout for some new topics and new webinars in the next few months. Again, I'd like to thank Dr. Hébert for being so gracious and giving the presentation today. So y'all have a great rest of today, and we hope to see you at the next webinar. Bye, everyone.